It's my pleasure to be here. I hope that this talk can reach the level of thought provocation that you've heard from the prior speakers. I think it's been an impressive session so far. It's my pleasure to be here. These are my disclosures. I want to take a couple of seconds just to emphasize the importance of this. This has come up at our board meeting recently, that when we have disclosures, the slide should stay up for more than 13 nanoseconds, and that we should identify what is a potential problem. And my potential problem here is that I have a consultancy relationship, not a shareholder, consultancy relationship with a company called FermTech, who are involved in this space. There's probably nobody sitting in the room at the moment who's not wearing some kind of wearable. This is just pervasive in our society at this point in time. The history of wearable penile devices, WPD, for the rest of this talk. For the older members in the audience, snap gauges, the use of Rigiscan, and now we're into the phase of smart rings and actually even smart condoms, which we won't even talk about. And I'm not talking about condoms from a contraception standpoint or STI prevention standpoint. I'm talking about condoms that actually can track penile health. So I think we're all aware, having listened to Marty Miner's excellent talk this morning, of erectile dysfunction equals endothelial dysfunction. This is not rocket science to this audience, and we know that the endothelium is a critically important part of our penis. This is from Princeton 4 Guidelines paper. If you haven't read it yet, I would strongly recommend you do. ED is a harbinger of occult cardiovascular disease or future coronary artery disease. It is irrefutable now in the scientific literature. So I think the concept now is one very kind of aligned with Mo-Kara's sex ban. Let's talk about erectile fitness, and this is really what wearable penile devices are aimed to assess at this point in time. The current ED investigation, of course, is really very static. It's not done in real time or a real environment. And then we always encounter the problems of patients with regard to social desirability or disenfranchised grief when patients are telling us or not telling us about their true erectile function. From an ED investigation standpoint, of course, we take a history. There are questionnaires. There are many of them. Nocturnal penile tumescence and rigidity analysis. Rigidometry never really took on, although it probably is a very, very important tool. Duplex penile ultrasound, and there's advanced testing in the form of angiography or more contemporarily MRA. The challenges with nocturnal penile tumescence and rigidity analysis, of course, is that it assesses radial and not axial rigidity. And of course, if you have a lot of penile fibrosis, then you may overestimate the rigidity that's in that penis because of the radial rigidity assessment. It's entirely dependent on the presence of rapid eye movement sleep, and there are other factors, of course, many of them, that interferes with nocturnal erectional activity. And then there's some debate about what the normative criteria actually are. Historically, this is the snap gauge. This is the kind of dinosaur of NPTR. Adjustable band, 3 snap release fasteners, variable tension required to break anywhere from 90 millimeters to 160 millimeters of mercury, and assess rigidity but without duration and frequency. And then this went on to the Rigiscan, a unit that is attached to your leg with 2 rings, one at the base and one at the tip of the penis. And this had the advantage of measuring number, duration, rigidity, and there were, in the more modern version, tumescence activity units and rigidity activity units. So this was certainly a step forward. This is an example of a normal NPTR Rigiscan. 3 to 6 erections, 10 to 15 minutes in duration, 60 to 70% rigidity are the generally accepted normative criteria. This is somebody who has no nocturnal erectile activity, which might be technical or might be due to the fact that this patient has obstructive sleep apnea and has fragmentation of sleep pattern. So the tech ring, or smart ring, which is FermTech, the group have developed, is a novel elastomer with a hook and loop design, which is easy on and easy off, safe for overnight use. This is documented now in the medical literature. There's an app associated with this which collects real-time data on nocturnal erectile activity. Rigidity assessment is scored on a 1 to 10 point scale via sensors embedded in the elastomer, and data is uploaded to a server which is HIPAA compliant. This is a photographic representation of the tech ring. This is data that can be generated. This is a duration of erectile activity on the x-axis, and this is the number of patients and number of erections that occur. So we can get real-time, very real data on these patients using a very non-invasive device. This is the app. You can get a score. It can measure your nocturnal erection activity, or it can measure erections in the act of sexual activity, whether it be self-stimulation or partner-based relations. This is the comparison. Top is Rigiscan, and the bottom is a smart ring, and you can see the advantages already visually to the smart ring. So the current use is assessing nocturnal erectile activity, penile health, accessing sex-based data, performance, and then the correlational data possibilities with accumulating evidence to suggest that this concept that older men don't have good nocturnal erections is actually false, with very good evidence coming out from this group showing that older men actually have frequent and relatively rigid nocturnal erections. This is what I'm most interested in, and this is why I'm involved with this company, because I think the potential for this product is massive. And I'm going to focus on the concept of cavernosal oxygenation, the concept of Doppler analysis using a smart ring, a wearable penile device that could measure oxygen levels in the corporal bodies and that can assess waveforms in the cavernosal arteries. But there is the potential for calcification assessment in men with Peyronie's disease, for example, intravaginal ejaculatory latency time in men with premature or delayed ejaculation, and then even there's technology being developed to assess penile morphometry, so looking at penile girth and volume using nanotube sensors and using these wearable condoms that I alluded to earlier on. I think you're all very familiar with the concept of cavernosal oxygenation. Your penis is a big vein in the flaccid state, it's a big artery in the erect state. We need that balance between those two to keep the cavernosal smooth muscle healthy, and the chronic absence of cavernosal oxygenation can lead to structural changes in the smooth muscle. So the concept is the cornerstone of penile rehabilitation, which is a massive part of my practice at Memorial Sloan Kettering, of course, post-prostatectomy, post-cystectomy patients. How much rigidity is actually required to oxygenate adequately? Interesting question. When we talk about rigidity, it heavily relied upon the patient self-report. And wouldn't it be helpful to have a device that actually could measure cavernosal oxygen levels? I want to make a couple of assumptions before I present some data to you. The mean arterial pressure is about, in the average human being, 90 millimeters of mercury. The mean intracavernosal pressure at high rigidity is at least at mean arterial pressure level, so 90 millimeters of mercury. And Annie McCullough, many years ago, assessed cavernosal oxygenation, in quotations there, because we never really proved that it was cavernosal oxygenation, using laser oximetry in patients exposed to vacuum devices. So this has been looked at more than a decade ago, and yet we've made very little advances to date. So this is research that I did with Renan Tal, who was my dear fellow from Israel, who unfortunately passed away very suddenly a couple of years ago at the age of 41 years of age. 21 blood samples taken from men who are undergoing dynamic infusion cavernosometry, a fairly historical entity, but an outstanding assessment of erectile hemodynamics. 13 patients' blood specimens were collected at different intracavernosal pressures ranging from 10 to 90 millimeters of mercury. And what we showed was, not unsurprisingly, that at very low pressures, intracavernosal pressures, you had very low oxygen levels. But when you got to ICP levels above 45 millimeters, so probably equivalent to perhaps a 4 or 5 on a 10-point scale, you had excellent oxygenation, and that did not improve beyond there. So perhaps you don't need the level of rigidity that we're driving people to at the moment to oxygenate the penis fully. So, to have patients wear a wearable penile device which could measure cavernosal oxygenation during nocturnal erections or during sex erections, and if there was adequate oxygenation, how we define that's debatable at this point in time, then rehab would no longer be rigidity, but more oxygen dependent. And this may reduce the need for us having to use intracavernosal injections to induce penetration rigidity if men only need a 40 to 50% erection. Moving on to penile ultrasound, we know of its application in the field of sexual medicine. There are established hemodynamic cutoffs. However, the machines are cumbersome and very expensive. What if a wearable penile device could do hemodynamic assessment? You apply a ring to the base of the penis with appropriate sensors in there, and it actually measures peak systolic velocity and end diastolic velocity. There was a unit which I used for a few years, many years ago when I was at Loyola, called a Sonocyte Micromax, which was basically a cradle that sat at the base of the penis with two sensors on either side that were mobile around the axis of the penis and measured PSV and EDV without any B mode, without any assessment of the structure of the penis. It was only hemodynamics, but there's some basis for considering this as an entity. So the idea would be that a patient would come into your office and you'd apply a smart ring to the penis, and you could actually do a Doppler ultrasound without doing B mode and get erectile hemodynamic data in the space of 5 to 10 minutes, as opposed to the usual 30+ minutes that it takes for a penile duplex Doppler ultrasound. So the take-home messages are that wearable penile devices are here to stay. that more comprehensive erectile data is actually currently available than we've ever had before. The future application to cardiovascular health assessment, ED equals ED, is real, and I think the future of such technology is limitless. With that, thank you very much.